Good afternoon, all of you. I'm very sorry I'm not able to open my video somehow. But I welcome. I'm Dr. Megha Agrawal from Healthcare Sector Skill Council, and welcome all. I welcome all of you to the 27th edition of our Healthcare Insight series, which Healthcare Sector Skill Council do in collaboration with our industry partners on very niche areas to give you the upskilling awareness about some simple health issues which we usually ignore in day-to-day life. Today, I am honored to have our respected speaker, Dr. Virat Galhotra ji, who is professor and head Department of Dentistry and as well as additional medical superintendent from AIIMS Raipur. Thank you so much, sir, for joining us. Today, we are going to touch upon a very important topic, advancing pediatric oral health, early childhood caries. We all know early childhood caries is one of the most common chronic diseases which affects the children with far-reaching effects on their nutrition, growth, and overall well-being. But this early childhood caries is largely preventable through early diagnosis, timely intervention, and effective oral health practices. To gain valuable insights about the evidence-backed, research-based practices, I really welcome our honored speaker, Dr. Virat Galhotra ji, who has authored papers in national and international journals, also co-authored textbooks in pediatric dentistry, patent of custom periosteal implant for maxillary reconstruction and implant, and is awarded and honored by various awards in his journey. I welcome you, sir. Thank you so much.
Thank you, ma'am. And good afternoon, everyone. Am I audible, ma'am?
Yes, you're clearly audible, sir.
So I'll share my screen and let me start. Yeah, screen is visible, I hope.
Yes, sir, the screen is visible.
Right. So today's topic is advancing pediatric oral health, early childhood caries. I'll be covering this topic under these contents. And but first we'll see what is early childhood caries. Let us define what is it. So this is defined as the presence of one or more decade missing or filled tooth surfaces in any primary tooth in a child under the ages of 6 years. It has got many terminologies like comforter caries, nursing caries, tooth clearing neglect, etc. Yeah, earlier it was also called as nursing bottle syndrome or nursing bottle caries. And another part is severe early childhood caries. In children who are younger than 3 years of age, any sign of smooth surface caries is indicative of severe ECC. Or else we can also categorize as in the age of 3 years if the DMFS score is greater than 4. In the age of 4 years, DMFS score greater than 5. And for the age of 5 greater than 6, DMFS score constitutes severe ECC. Before beginning further, let's see what is the epidemiology. Various studies globally, it has indicated a prevalence of 16 to 89%. From the systematic review given by Irway et al. In 21, a global pool prevalence of 48% was reported, according to which you can understand that 530 million children globally were affected with dental caries of primary teeth. And what about national? Nationally, we have overall pooled prevalence of 49.6%, with Andhra Pradesh reporting the highest prevalence of 63%, and Sikkim being the lowest with 41.92%. This is a map of India where you can see various states with their prevalence rate, all the green boxes indicating the studies reported. And you can also clearly see in anywhere all the states the prevalence is not less than 40%. So, which means this is a serious public health problem. And the red boxes, these states are underreported, and further research needs to be conducted in these states. So, coming to the sequelae of the disease, what will happen after this severe ECC or ECC? First and foremost is pain and abscess, which leads to inability to eat, leading to compromised sleep of the child as well as their parents, and it will affect their growth. It is important to treat ECC at the earliest since it may lead to premature loss of primary teeth, which leads to loss of arch length, aberrant tongue habits and speech problems, altered eruption patterns, psychological effects, and compromised aesthetics. Etiology and risk factors. Regarding the etiology, it is same as that of dental caries, that almost all the dentists are well versed. We know that there is metabolism of sugars by the tooth adherent bacteria to produce acids, which over time demineralizes the tooth structure. Regarding the risk factors, it is believed to be a multifactorial disease with primary as well as secondary risk factors. These some of the risk factors of under the primary are dental plaque, S mutans, infant feeding pattern, toothbrushing, etc. Under the secondary, we have immunological factors, tooth maturation or defects, race, ethnicity, and socioeconomic status. But first, let us see how is it different from permanent teeth caries. This is the ECC is rapid in progression, and that makes it different from adult caries. You can notice here white spot lesion, whitish discoloration you can clearly see in the picture. So this progresses further with the leading to the enamel breakdown, further going into dentin exposure, pulpal involvement, and leading to the tooth loss, complete tooth crown structure. This is how it is different from permanent tooth caries. So the first step is diagnosis. Let's see diagnosis under two parts: early detection and risk assessment. Earlier, we used to, in our graduation, we used to do the WHO criteria of DMFT or DMFS, according to which either we mark caries present or absent. But it has its own disadvantages. So initial stages in primary, like I showed you earlier, white spot lesions are missed. You cannot record according to WHO criteria. So the paradigm has shifted from traditional restorative approaches to more preventive and patient-centric models. So this has led to the development of international caries classification and management system by several researchers from UK, USA, Denmark between 2010 to 2017. And they have the aim of this system was to prevent new lesions from appearing, to prevent existing lesions from advancing further, to preserve the tooth structure with non-operative care at more initial stages, conservative operative care at more extensive caries stages, while managing the risk factors and periodic monitoring and recall. I'm not going into the details. This is beyond the scope of this today's lecture. If anybody is interested, you can see scan this QR code to visit the ICCMS website and go into the depth of this topic. Next step was International Caries Detection and Assessment System, also known as ICDAS system, which was considered as the predecessor of ICCMS. And it is a simple, logical, evidence-based system for detection and classification of caries in dental education, clinical practice, dental research, and dental public health. And it was developed in 2002 in Scotland. This is the scoring criteria for ICDAS. You can see 0 is a sound tooth structure. Score of 1 is first visual change in enamel on drying. 2 is a distinct visual change in enamel without drying. 3 is localized enamel breakdown without clinical visual signs of dentinal involvement. 4 is underlying dark shadow from dentin with or without cavity. 5 is distinct cavity with visible dentin. 6, extensive distinct cavity with visible dentin. So let's see the evidence also. This is evidence with from 2018, where they compared the ICDAS system with WHO criteria, and the authors concluded that ICDAS 2 system might be superior in detection of incipient caries and can be of specific value in prevention of early childhood caries. Second part is the risk assessment. Risk assessment, there are many tools available in the literature, in the market, but in our department, we use the camera risk management by caries management by risk assessment. It was developed in 2002 by California Dental Association. Later, Ramos and Gomez and Featherstone completed in 2007, and it's continuously being updated. And in 2007, it was published in Journal of California Dental Association and updated in 2019, and has been utilized over a period of more than 15 years. So camera is a quantitative component to better determine the caries risk level. Under this, we have this form from ages of 0 to 6 years. There are 4 categories. 2 are question forms. First is biological questionnaire, and second is protective factors. And the 2 are clinical examination regarding the biological risk factors and the disease indicators. Accordingly, we compute the score and we categorize according to the low, moderate, high, or very high. And this is the scoring criteria. Low risk, when the total score comes to -4 to -1, moderate 0 to 3, high risk 4 to 13, and very high risk 14 to 18. I'll give you an example. Let's say this is an example from our department, 3-year-old male, and this is the pre-treatment record. You can see the ICDAS scores of 2, 3, 4 in respective teeth, and we computed this camera. And according to the questionnaires, 2 questions, 2 categories question. Patient's mother had current decay. We gave the +2. Family has low socioeconomic status and low literacy status, +2. Whereas she lives in a fluoridated drinking water area and drinks fluoridated drinking water, then a score of -1. And here also my drinks fluoridated water, -1. So, but he has evident tooth decay on clinical examination. So +3 score was given. So when computation was done, score of 5 we got, and we categorized the patient as high risk category. So after diagnosis, let's see the management part. These are the broad categories which we'll deal in detail. But the caries management is based upon risk assessment. What we have done, based upon that, if the patient comes under low risk, we have to subject the patient to fluoride toothpaste twice daily, 6 to 12 months recall, and radiographs every 12 to 24 months. When the patient is under moderate risk, there are certain self-management goals like diet counseling needs to be provided, fluoride application, fluoride toothpaste daily, and pit and fissure sealants, and fluoride varnish every 6 months, and 6 to 12 months radiographs. Another high-risk category, it's fluoride varnish, pit and fissure sealant, self-management goals, restorations, if required, ITR, and 3 monthly recall, and 6 months radiographs. Under the very high risk, apart from this high risk category, we need to call here monthly. Radiographs are 6 monthly, and caries control is required prior to giving any definitive treatment. So these are some of the caries self-management goals under various factors: protective, carbohydrate changes, sugar control options, oral health, lifestyle. You can enforce two goals every visit. You can ask the patient to attain two goals each. So, with this alarming evidence of high prevalence of ECC, WHO in 2019 has come up with implementation manual. You can scan this QR code if you want to go through the manual. S- Even the American Association of Pediatric Dentistry also endorsed these implementation manual, and they both endorse certain measures like brushing twice daily with an age appropriate amount of fluoride containing toothpaste, and then use of fluoride for caries prevention as it is safe and highly effective. Receive professionally applied topical fluoride treatments at least twice per year. Use of mouth rinses for high risk patients over 6 years old. Fluoride dietary supplements for children at risk who drink less than optimally fluoride water. In order to address ECC, the primary goal must be to control moderate, modifiable risk factor, most important being infant feeding and diet in young children. First is regarding the infant feeding. Always promote, protect, and support your exclusive breastfeeding till 6 months. Later, after 6 months, introduction of solid foods, but at the same time, continued breastfeeding should be done up to 2 years. This is as per UNICEF. Limit consumption of liquids containing free sugars, including natural sweetened juices. Limit consumption of complementary foods that contain free sugars. Encourage a combination of different foods that is high in fruits, vegetables, and low in free sugars. Second factor is fluoride. Toothbrushing twice a day is being recommended by American Association. It should start as soon as the first tooth erupts, and it should be done by parents till the age of 6 years. Now the question comes: what to use? Fluoridated versus non-fluoridated toothpaste. Lot of debates going on. Let us review what the evidence tells us. This is a evidence from Cochrane database of systematic review, from which authors concluded that brushing infants and children's teeth with an affordable, effective fluoride-containing toothpaste should be routine. And for infants, for young children, the concentration of fluoride should be 1,000 to 1,500 ppm. And brushing twice a day is more effective than less frequent brushing, as it maintains adequate fluoride around the tooth for a greater proportion of the day. Later, in 2016, again from the databases of systematic review, it included 96 randomized controlled trials between 1955 to 2014. Authors concluded that there is high certainty of evidence of using 1,000 to 1,250 fluoride ppm fluoride toothpaste, which is more effective than non-fluoride toothpaste. American Association has recommended appropriate toothpaste usage as children, if the children are less than 3 years of age, smear or rice size amount to be used. For 3 to 6 years, a pea size amount containing 1,000 ppm of fluoride. These are some of the toothpaste which are available, which are marketed as fluoride-free toothpaste available commercially. But the evidence, as per the recent update on clinical evidence by Dr. Hardy Limeback, various materials he analyzed: hydroxyapatite, CPP, ACP, calcium sodium phosphosilicates, beta tricalcium phosphate. Out of these, Hydroxyapatite-based fluoride toothpaste appear to be most versatile option among calcium phosphate toothpaste for improving oral health. Systematic review and meta-analysis also they concluded that there is good evidence that hydroxyapatite in oral care products in the absence of fluoride effectively reduces caries. But additional clinical studies would help identify the most effective active ingredient. So the key takeaways: WHO and AAPD has always recommended use of fluoride as a safe and effective way to prevent cavities. Fluoride-free toothpaste may be marketed, but there, as far as no scientific backing for caries prevention. Next management goal is pit and fissure sealants. I think most of the dentists must be doing it. The indications are deep retentive pits and fissures, stained pits and fissures with minimal appearance or decalcification or opacifications, no radiographic or clinical evidence of interproximal caries, educate isolation from salivary contamination. The contraindications include well-coagulated self-cleaning pit and fissures, evidence of interproximal caries, no adequate isolation can be achieved. The procedure, it's similar. You have all done isolation, cleaning the tooth, etching, rinsing, drying, sealant application, polymerization, and then evaluating the sealant. Sealants should be evaluated every recall visit. If there is loss or partial loss, it should be replaced. And regarding the evidence from Cochrane databases of systematic reviews, this is regarding the use of pit and fissure sealants in primary teeth. The quality of evidence is low or very, very low, so conclusions cannot be drawn. In permanent teeth, it says that resin-based sealants versus no sealant reduced caries between 11 to 51% at 24 months and up to 48%. So the evidence was moderate quality evidence. Regarding GAC sealants versus no sealants or one sealant versus another sealant, there was very low quality of evidence. Next is fluoride varnish, which is professionally applied topical fluoride twice per year. And in our department, we use MI varnish, which is 5% sodium fluoride with 2% CPP, ECP, and using a paint-on technique for 4 minutes. Next is fluoride gel, which is an alternative to the varnish. You can use APF gel at 1.23 concentration with 4 minutes in each arch. Regarding the evidence, there is a strong evidence that topical application of fluoride varnish 2 to 4 times a year can reduce development of new carious lesion into dentine or the need of restoration of teeth. Fluoride varnish can reverse incipient carious lesion in primary teeth and promote remineralization of early enamel caries in children. Next is silver diamine fluoride, introduced in 2014. This is a 38% solution used to arrest caries in primary teeth. It is a non-invasive procedure. It is quick and simple to use. Regarding the mechanism, silver diamine fluoride, when applied, it splits into silver and fluoride ions. And silver acts as antibacterial and fluoride helps in remineralization. WHO has recommended annual or biannual application of SDF. These are some of the commercially available SDF in the market. Regarding the indications, it is indicated to arrest active carious lesions when there is dentinal hypersensitivity in preoperative children and adults whose behavior or medical conditions limit invasive restorative treatment. Contraindications being if patient is having symptoms of irreversible pulpitis or dental abscess, any signs of radiographic signs of pulpal involvement or periradicular pathology, ongoing active lesions, any patient allergic to silver, and patients with ulcerations, mucositis, or stomatitis. So how to apply after obtaining informed consent, because there is a lot of discoloration. Then apply Vaseline on the soft tissue. Isolate the tooth to be applied. Take one drop, single drop, for apply it for 1 minute, and let it dry for 3 minutes, and then air dry it and rinse with water. This is how it will appear, the blackish discoloration. That means the caries is arrested. According to an RCT on the effect of LED, they used for 20 seconds after 10 seconds of SDF application appears to facilitate silver penetration, which is similar to a 1 minute SDF application. The post-operative instructions, usually there is as such no post-operative instructions. You can patient can eat and drink immediately after the application. Patients may brush fluoridated toothpaste as per regular routine following SDF application, and recall has to be done after 2 to 4 weeks. Evidence literature again supports annual or semi-annual application of 38% SDF solution, which is effective in arresting dental caries progression in primary teeth. One of the major drawbacks of SDF is the blackish discoloration of the tooth. Hence, various stain mitigation strategies have been tested. Evidence suggests that addition of different materials to SDF has proven to be beneficial strategy for overcoming tooth staining associated with SDF. However, future studies are warranted, particularly clinical trials, to validate these findings. Next is traumatic restorative therapy. It is a placement of dental adhesive materials, usually minimally invasive techniques. Does not require local anesthetic injection, suitable for young children who may not cooperate during the treatment. Again, the evidence based upon meta-analysis, survival of single surface ART restorations using high viscosity glass ionomer in primary teeth is high. Lastly, health education and community engagement. Spreading awareness through oral health education program is must. These are some of the pictures which we routinely do regarding the awareness. Even the brushing demonstration is given to the children as well as the parents, and the evidence also. From the evidence, this is concluded that providing oral health education to the parents and caregivers on ECC risk factors may reduce the risk of ECC. So I'll show you a few of the cases which are contributed by my residents. This is a 4-year-old female with pre-treatment. You can see the intraoral record of ICDAS. You can see 3, 4, 5 in the respective dentition. And a patient was subjected to camera. And after the computation, we came up, patient was categorized as very high risk. So the first step is in the first appointment, preventive appointment, the explanation of dental problem and concept of the prevention is given to the parents. This is how handwritten concept is given to the parents. Second step is we do the caries activity test. There are a lot of caries activity tests, one of them being aura test, which is simple, but it's in this case, we did not get any color change. Then third step is gingival bleeding index to be recorded. And then patient needs to be subjected to plaque disclosing agent, and plaque, once it is disclosed, plaque index needs to be done. After this, you have to record 24 hours diet diary from the parents. And last step is in this appointment, first appointment, you need to seal any open carious lesion, either with glass ionomers or temporary restoration. You can do it. After this, next appointment is given after 10 days, wherein patient was asked to collect 7-day diet diary. Parents were asked to give it. And at the same time, in the step 2, we explain explanation of the disease process to the child as well as the parents. was done, and professional oral prophylaxis was imparted to the patient. This is how diet diary is being done. After this step, the dental caries recording as per ICDAS was done, and discussion of the previous appointment regarding the aura test, gingival bleeding index, and plaque index was done. And lastly, application of topical fluorides. We use MI, and 4 minutes we applied on the patient's upper and lower arch. Next appointment, number 3, after 10 days, the complete dietary analysis and counseling was done according to the recommendation. Deficiency or excess was told to the parents, and they were counseled. And at the same time, sugar exposure was explained to the parents at the same time. And again, GBI and PI was recorded in this appointment, and definitive treatment was started for composite restorations in certain teeth, pulpectomy, strip crowns, etc. And next appointment, after 1 month's time, again GBI was recorded, PI was recorded. These are post-op treatment pics. Then at the termination level appointment, the GBI was recorded, again PI was recorded, and this is how the summary appears. See, you can appreciate from the first appointment, GBI and PI it decreased till 4th appointment, but PI increased from 4th to termination. Although it is under the prescribed levels of termination, however, patient was again counseled for taking proper oral hygiene practices. This is the summary of treatment provided, and this is 1 year follow-up. Here you can appreciate from pre-treatment, post-treatment. This is 1 year follow-up. Last case, on similar grounds, ICDAS was recorded 3, 4, 5. Patient was under high risk category. Again, explanation of the dental problem, aura test, GBI and PI recorded, diet diary, and sealing of open caries lesion. After the second appointment, diet diary was collected, explanation of the disease process, professional oral prophylaxis, ICDAS scoring was done, discussion of previous appointments, oral test, GBI and PI, any application of topical fluorides. Next appointment, analysis and counseling regarding the diet was done, including the sugar exposures. GBI and PI recorded. Definitive treatment started here. Then next appointment, GBI, again PI recorded. Fluoride varnish was reapplied here. At the termination level, again GBI and PI was recorded. And camera was also recorded here from patient which was from high risk. It came to be under moderate risk. And this is the summary from this percentage to this. And this is what the summary of treatment. And you can appreciate the treatment with a 1 year follow-up. So to conclude, ECC is a pressing global health issue among other non-communicable diseases. We are at the forefront of this battle, and to champion early diagnosis, implementation of effective prevention strategies, and ensure access to care for all children. So I acknowledge my pediatric dentistry team here who have helped me in making this lecture. And thank you from my side. And if any questions are there, we can take up.
Um, any queries from anyone? Please put up your queries on chat. Dr. Dhures, I think so. He has raised his hand.
I see the chat.
Dr. Dhures, you want to
Yes,
ask something?
yes. Thanks for this meticulous presentation. Obviously, it's a very good presentation. And you have mentioned one thing, the fluoride containing the toothpaste we should use, and that's evidence-based.
Yeah.
But the common people actually, they are very much confused.
Yes.
And especially they are confused because of the advertisement, whatever going on in the different TV channel or media. They are mainly through that they are actually buying the toothpaste, and they don't consult with the dentist for what toothpaste they should use for their children. So this is one aspect, sir, and another one is uh, for the adolescent children or whatever adolescent period. Any recommendation of toothpaste is there?
Same fluoride, 1000 ppm to 1500 ppm.
Oh, for adolescent also these are good.
Yeah. Now the evidence has changed. So WHO and AAPD both have recommended. WHO, we follow WHO. They are given in clearly as the you can say evidence regarding this use of this 1000 ppm even in children. But the amount of toothpaste to be prescribed, that is very important. So, we have a lot of queries here, like you are asking in the market, because issue is we do not follow the complete instructions. They have like AAPD has clearly categorized that under less than 3 years of age, only a rice size amount of toothpaste to be placed on the toothpaste to be placed on the brush. But what we do, what parents, they generally do not consider these instructions.
Yes,
They
yes,
just, that
yes.
is the concern.
So the extensive awareness is actually required for the common people aspect. So
Ye-
more awareness, and then will be.
Yes, more awareness, because what we have found, we are doing lot of preventive talks, we are doing lot of prevention with the parents. Even the well-educated parents we are seeing here, they are not aware about the what preventive strategies are there. They
Yes,
come
yes,
when disease has progressed.
yes, obviously. And another one issue I would like to mention, as I am practicing geriatric medicine.
Yeah.
Okay, so the dental issue and the oral issue is very much in the geriatric age group,
Yes.
especially for those who are super aged and bed confined, and the other some post stroke aspect, and mainly that sort of the where they are totally dependent on the caregivers, and that, and oral hygiene is actually not maintained properly, and that for that reason they are even nutritionally they are hampered and severely hampered. Okay, the oral some fungal infection, oral candida, these are very common aspects in the geriatric age group. So,
Yes.
and then to address that, you not only by the doctor but also the family member, the caregivers, all should be
all,
responsible or take care.
all are
So,
integral parts, sir.
yes,
They
sir.
are
So in
integral.
that aspect, I would like to request the HSSC and you also.
Yes,
So
sir.
on this topic, geriatric dental care, you can arrange because it's a very pertinent issue, sir. Because I have seen in my home-based care, lots of the elderly people, their oral hygiene is actually minimally maintained.
Mhm.
Okay, and uh, some of them are not able to actually visit the dental clinic or aspect also because of the age, because of the no companion. So if the home care is available, at least for the primary screening of this denture problem, so it will be much more beneficial for the to address the larger section of the elderly group.
Yeah, I think awareness programs, be it of any age, it has to be there. It has to be there. or even old age. See, हम लोग बोलते हैं ना, बुढ़ापा एक बच्चा ही बन जाता है बूढ़ा होना.
एकदम. हाँ हाँ.
So the similar consequences like we see in children, the same consequences, like more worsen consequences you can see visualize in geriatric patients.
Yes, sir. Thank you. Thank you very much.
Thank you, sir.
Anyone else have any queries? So meanwhile, they are posting their queries. Can we ask some queries from you? Can we predict which child is going to develop these early childhood caries? Can we
Madam,
make that prediction?
like it, we cannot predict with certainty. What I gave you, like Canberra or risk assessment tool, these are tools which can predict to a certain level. You cannot. There are I told you that it is a multifactorial disease. Multifactor, there are many number of factors involved. We are relying on some of the in camera we are relying on the 4 factors. Apart from them, there are other factors which can influence. We cannot 100% predict, but we can give an idea that this patient is and will be a high risk or low risk or moderate risk. We can just do that. 100% we cannot.
Right, sir. Sir, if a child gets a carie in their milk teeth, and milk teeth in any case get to fall off and replaced by the permanent teeth, in that case,
That, that
what
is
care they should take up
that is
for
our
that milk teeth? And
biggest notion in Indian मतलब population, what I'll say, दूध का दांत है गिर जाएगा. But see the consequences what will happen is there is this first speech development. बच्चे का स्पीच बन रहा है, mastication खाना खा रहा है, like these all problems they will not functional completely. Then some most important what we see is psychological impact. आप कभी भी स्कूल में एनालाइज करिए, कभी क्लास में आप इवन इन अमंगस्ट योर फ्रेंड सर्कल, बच्चे का जो दांत गिरा होता है या केरीज होती है, ब्लैकिश दिख रहे हैं, he will not smile, he will try to hide like his teeth. He will be very conservative. That has impacted his psychology. We are not giving that factor any importance. So and lastly, आपका जो उस स्पेस पे परमानेंट टीथ आना है, विद टाइम देर इज अ स्पेस लॉस. मूवमेंट हो जाती है अगर खाली एरिया है. जब वेंस देर इज मूवमेंट, स्पेस लॉस इज देयर, परमानेंट टीथ को जगह नहीं मिलेगी. देन अगेन वो ऑर्थोडोंटिक ब्रेसेस में जाएंगे. सो यू हैव टू प्रिवेंट दैट. सो दैट इज व्हाई दिस इज वेरी इंपॉर्टेंट.
right, sir. Sir, there are sometimes other cases we see that there are no caries as such, but there is still a bed breath, even though the child is, especially with the adolescent children, where obviously the parent supervision is not on their head for brushing the teeth. They are doing it independently, but still there is a bed breath problem. So what we should advise them?
Well, halitosis, basically we call it as halitosis. Why this happens? There are many factors, but one of the most important we discussed the brushing habit. One is brush kar raha hu main. One other thing is you are doing proper brushing with proper technique, and most important recommendation is night brushing, mandatory for everyone, and morning brushing after breakfast. What we do in the morning, night is avoided, it's gone. So the halitosis will definitely occur. This is the recommendation which we need to be telling all the parents or adolescents. We need to make aware that of these things, and certain Like if adults, like some of the food products also, they degrade later on and they cause halitosis. So counseling, diet counseling, everything is an integral part for this.
Right, sir. And sir, what will happen that if after a meal, after each meal, would they rinse only the mouth rinsing with the normal water is fine, or they should use the mouthwash?
After, see, after every meal, mouthwash, this simple oral rinse is fine. The food should not stick on the tooth. That is the concern. Any sticky foods. Night after your dinner and everything, it is mandatory. Last thing before going to the bed is brushing. Only afternoon meal is left, which you can go for oral rinse.
Right, sir. Sir, if fluoride toothpaste is being used twice daily, why would the child still need the professional fluoride varnish? You have recommended that twice
Yeah,
a year.
fluoride varnish is recommended in cases of when we categorize patients, like it is a high risk case or very high risk. In such cases, I have shown you the decision tree. For such cases, we recommend fluoride varnish. What happens is toothpaste is low concentration of fluoride. So even though it is effective, but in such cases, in the high risk category, you need high concentration of fluoride. So professionally, once we apply, we deliver a high concentration of fluoride. So that helps you sustaining the caries.
Right. So you have mentioned about the white lesion on the teeth for the children. How the parents can basically screen that because obviously first most thing is that parents should be aware that they have to go to the dentist. But
Yes.
how they would be able to
See,
differentiate it?
see any white spot लीजन जब आप एक एंगल से देखेंगे ना टूथ को कभी भी, और सबसे ज्यादा इंपॉर्टेंट है जैसे ही आपने ड्राई किया एरिया को आपको व्हाइट स्पॉट दिखेगा. That is the initial step. If you during that time we can prevent, then it will not progress.
Right.
So that is the time immediately jana hai.
Right, sir. Anyone else have any queries? I think so. We don't have any queries. In that case, I think so we can close our session. Thank you so much, sir. Thank you so much for your insights. As Dr. Dhiresh has recommended and suggested and requested, we will come back to you if we can have a similar session for our geriatric patients as well, that how they can manage their caries
Definitely.
and have the oral care. Thank you so much, sir.
Right. Thank you, madam. Thank you.
Thank you very much to all the participants for joining in. And we will come back next month with our next session with a niche topic, again, an important topic.
Thank you.
Dr. Soni, you want to say something?
No, thank you, ma'am.
Okay, fine.
Thank you.
Thank you.
Thank you very much.
Thank you. Thank you.
Thank you, sir, very much.
Thank you, ma'am.
Nice session
Thank you,
here
sir.
by you. Thank you, sir.
Thank you.
Thank you.